Good afternoon, students. Myself, Dr. Umiya Pathan. I'm from Patil College of Physiotherapy. Okay. So, name of today's topic is gait deviations at knee joint and ankle joint. Okay. So, content of these topics are deviation of gait occurs at a knee joint, and we will be seeing deviation of gait occurs at the ankle joint. So, objectives of this lecture are at the end of this lecture, second BPTA student should be able to define the types of gait occurs at knee joint, types of gait occurs at ankle joint, and they are able to describe the different abnormal gait patterns occur at the knee as well as ankle joint. So first we will see about the knee joint. So first one is gait with knee hyperextension. So this type of gait occurs due to spastic quadricep group of muscle, weak hamstring group of muscles, and tightness of tendocalcaneal muscles. Usually, this type of gait is seen in hemiplegia. So here, knee remains in hyperextended position. Usually, this gait is seen in stance phase during the foot flat. Okay, and it is due to the fixed plantar flexor deformity. So I have a video, just see how this gait will occur. See, gait with hyperextension. Second is flexion attitude at knee. So this type of gait occurs in the stance phase during the initial contact or at the heel slide. So usually what happen here, knee is going to be buckle, okay, or knee is flexing. So usually what happen due to the knee flexion contracture, or there will be if there will be a spasticity in flexor group of muscles, uh, knee is unable to extend. Okay, so due to this knee is unable to extend, the foot tries to contact on the ground. Usually, this kind of deformity, this type of gait is seen in cerebral palsy patients. It is also due to the weakness of quadricep muscle, which is seen after the patelectomy, where extension lag is there. So in this, it occurs in at the position of heel off, okay, and from acceleration to mid swing position. So here, knee flexion is more than 40 degrees. Now see, his knee is going into the more flexion position. Just see on the right side knee, that is not going to be extended. Okay, so this is the flexion attitude due to the weakness of the muscles, due to the weakness of a plantar flexor group of muscle. Now, third one is a hand-on knee gait. This type of gait occurs during the heel slide in the initial contact, in the swing, in the stance phase of gait cycle. So this occurs to prevent excessive flexion, okay, or excessive buckling of knee. Usually, excessive flexion occurs when there will be a weakness in the quadricep group of muscle, or paralysis of um paralysis or weakness in the hip extensor group of muscle. That time, what happen? There is a excessive flexion of knee joint, and to prevent that excessive flexion, patient tries to push the knee into the extended position. See this. See how he is walking. So fourth one is a genu valgum or knock knee gait. Usually, this type of gait occur in medial collateral ligament weakness. Okay, usually it is seen in rickets, secondary to coxa deformity. So here, IT band is going into the contracture, so that patient develops habitual walking on the medial border of foot. Okay. See, uh, see how patient walk. This is called genuine gait. Okay. Now next one is a ankle joint. Okay, we'll see now ankle joint. Gait occurs, different type of gait occurs at the ankle joint. So first one is a foot slap gait. Usually this occurs in complete foot drop where the paralysis of foot flexor is there. In that condition, you can see this. So at the heel slide, when patient tries to strike the heel on the ground, the forefoot is going to be slapped, okay, on the ground, as the dorsiflexors are unable to control the movement from heel strike to foot flat. Okay, so patient is not having that control, so his foot is slapped on the ground. So this will be due to the mild weakness, okay, or paralysis of flexor group of muscle. So in mild weakness, what happen, initial contact is made with heel followed by a rapid ankle plantar flexion which causes foot slap. So during swing phase, sometimes what happen, during the swing phase, that leg is going into the drag. Okay, the toes will be going into the drag. Okay, so to compensate this, there is a excessive flexion at hip and knee joint. See, see foot. Just see her left foot. Okay, so the stages are absent. Heel strike is absent. Mid stance is absent. Her foot is directly slapping on the ground. So second one is a high steppage gait. Usually, this type of gait occurs in the paralysis of dorsiflexor group of muscle. So, in later stages of stance phase, it occur in later stages of stance phase from foot flat to toe off. So here the dorsiflexors are unable to control the movement. Okay, or there will be a extensive plantar flexion occurs in this phase. So here plantar flexors compensate trying to step high by excessively flexing the hip and knee. So I have a video, just high steppage gait. See, his right limb, okay, is performing excessive flexion. Okay, so this flexion is more than 40 degree. Okay, flexion at hip as well as he is doing flexion at hip as well as knee. Okay, so next one is a equinus gait. So this type of gait occurs in the polio patients. Okay, this is also occurs in the stance phase. Okay, here the plantar flexors are very strong. Okay, or there will be a fixed plantar flexor deformity. So ankle is going to be into a plantar flexion throughout the stance phase. Okay, and hip and knees are extended. Okay, it is related to the spasticity and contracture of ankle plantar flexor group of muscle, or there will be a weakness in the dorsiflexor group of muscle. It may be present with compensatory to genu recurvatum. See, is walking on 4 foot. Okay, her leg is into the plantar flex position. It is due to the fixed plantar flexion deformity. Fourth one is a calcaneal gait. It is also called as a gastrocnemius and soleus gait. Okay. So the dorsiflexors are here. The dorsiflexors are strong and plantar flexors are weak. So the calcaneal juts out, okay, and patient tries to take weight on the calcaneal, on the calcaneum. Okay, it will leading to apparent lengthening of plantar flexor group of muscle, and here toe off is absent as patient is walking on the heel. Now see this video. See how he is walking. See the walking on the heel. So here the dorsiflexors are very strong. Okay, and plantar flexors are very weak. Okay. Fifth one is varus foot gait. Usually it occurs in varus deformity of foot. So here patient walks on the lateral border of foot. Okay. Here the tendo Achilles muscle, posterior muscles of ankle joint and inverters are very strong. And the medial side arches are excessively high. This varus gait. See how she is walking. So next one is a valgus foot gait. Usually it occurs in the valgus deformity of foot, of the knees. So here patient try to walk on the medial side of the foot. Okay. Here the peroneal group of muscles are very strong. Okay. And this group of muscle goes into the contracture. The inverters are weak and the medial arches of foot, they are falling down. Okay. Now, the flat foot gait, or also called as a pace planus. So here, the both medial as well as lateral arches are weak, and there will be a laxity of spring and deltoid ligament. So the tensile strength of the ligament is reduced. The both inverters and everters are weak. See how patient is walking. See. So the patient is directly going foot slap. Okay. Uh, not only slap, patient is keeping whole foot directly. Heel strike is absent. Heel strike mid stance is absent. Okay. Then eighth one is a pace cavus gait. It is due to the exaggeration of arches of foot. So here patient tries to walk on calcaneum. Okay. So patient is walking on the calcaneum. Okay, and toes are flexes on the ground. Okay. So the both arches are exaggerated. So I don't have the video. Okay. So the position is, suppose this is the heel and these are the toes. So the arch and these are the arches. Okay. So the foot are like this and patient is walking like this. So in this pace cavus gait, there are more chances of fall of the patient because the support is very less. Support on the ground is very less. Next one is a toe drag gait. So it occurs in the pre-swing phase. It is due to the weakness or flaccidity of toe flexors as well as extensor group of muscle. So insufficient dorsiflexion movement occur during the toe off phase. Okay, so that patient is unable to perform dorsiflexion. So the toes are unable to clear the ground. Okay, so during the heel off, patient is unable to perform the during the heel strike, patient is unable to perform the dorsiflexion. Okay, so these toes are dragging on the ground. Okay, dragging to clear the ground. See this video. See his right foot, how he is dragging his toes on the ground. Okay, there are chances of fall in this game. Next one is a fall of head of first metatarsal. So it is due to the weakness of tendocalcaneus muscles. So that what happened due to the weakness, the extensor hallucis longus, it becomes into the action. Okay. So instead of heel strike, patient puts weight on first metatarsal, and patient is walking to taking weight on the first metatarsal. I don't have a video of that. Next one is a broad base gait. So here in this broad base gait, the center of gravity is lower. Okay. And due to that, patient may fall forward. Okay. So this patient tries to widen the support, okay, and walks with the broad base. So this type of pattern is seen in the patients who are having who are suffering the problems with balance, or the patients who are having loss of proprioception, loss of toe sensation, in cerebellar lesions. Even in pregnancy, you can see this type of gait. In patients of vertigo, you can see this. Broad base gait. Next one is the Parkinson's gait or shuffling gait. So this type of gait is characterized by small steps. Patient is trying to take small steps. Patient's posture is stooped. Okay, so that attitude of posture is usually flexed posture. Okay, so in this type of gait, step length is diminished, and there is a rigidity in pelvis, thorax. Okay, arm swing is reduced, postural instability is there. Okay, shoulders are protracted, hips and knees will be in flexed position, trunk is in the flexed position. Usually you can see the bradykinesia in these type of patients. So motions are become slow. Okay, and patient is unable to change the direction. So so that the patient, while changing the direction or while turning, patient is taking very short steps, and then he is turning or changing the direction. So usually it have a flexed posture as a center of gravity falls forward. So patient makes to attain this regain of balance by flexing the trunk. Okay, and there is a difficulty in initiating and terminating in the gait. It is also called as a fastignant gait. See how this gait is occurring. Fastignant gait. See, patient is having stoop posture. He is taking small steps and moving forward. Okay, stoop posture with arms protracted, hip knee flexed, trunk is in flexed position. Okay, now see how he is turning. Okay, it is also called as a fastignant gait. Okay, so summary is, today we have seen the different type of deviations which occurs at the knee joint, which these are the gait with knee hyperextension, gait with flexion attitude at knee joint, hand on knee gait, genu valgum or knock knee gait. In the ankle joint, we have seen foot slap gait, high steppage gait, equinus gait, calcaneal gait, varus foot gait, valgus foot gait, flat foot gait, also called as a pace planus, pace cavus gait, gait with toe dragging, fall of head of first metatarsal, okay, then broad base gait, And last one is a Parkinson's gait or shuffling gait. Okay, thank you. Sorry. So I have taken this from these two books, and I have taken the videos from the YouTube. So these are my references. Thank you.